So this is the beginning of our presentation. My job here is to try to convince you that the 4 French, which means a small puncture hole, is not limiting your intervention, but probably broadening the scope of your interventions. And in my practice, majority of 4 French cases is going downstream to the common femoral or superficial femoral and doing critical limb ischemia. However, I think we deserve an easier case from time to time, and this is such a case. It's a relatively young 56-year-old male with bilateral claudication, and on the right we have right external artery stenosis and right superficial artery stenosis, and on the left we have a 10 centimeter occlusion of the LSA. So these are the questions. Can I do both limbs in one setting? Can I use full French platform to do everything and stay safe? Because that was the plan, to do everything in one setting, not split it into 2 interventions. So that was the plan, going from the left to the right. And of course, we are using full French platform, and we are intending to use full French 65 centimeters fortress sheath. And we crossed to the right side. This is a very short stenosis. I don't see that many stenosis of that kind, so I was kind of hoping that using just a 7-millimeter balloon will fix that without having to stent it. Unfortunately, this wasn't the case. You see the small ring stenosis popping out. And the other slide is showing you to demonstrate that you can easily retrieve the 7-millimeter balloon through a full French sheath without much friction. So this is the final result. Unfortunately, you see dissection. Well, we can argue that this is not flow limiting, but I wasn't, I didn't want to leave it like that. So I took a stent, which is Pulsar 7/40. This is the old type. We will be using the new one in a minute. And we stented the origin, the ostium of the right external artery. And this is the post-implantation result, which is, I guess, more than perfect. And then we went down. This is just to remind you how the release mechanism of the old stent is working. This is a trigger mechanism. I will compare the both stents in a minute. So this is, again, a very short stenosis in the SFA. I don't see that many such stenosis. And since this is task A, we can get away with a plain old angioplasty. You don't have to use drug-eluting balloons for task A because the results are pretty much the same. This time we got away without stenting. Good result after just plain 5-millimeter balloon. And we are going back to the left side where you see a typical occlusion midsection of the SFA. Probably we'll have to stent it since this is a 10 centimeter occlusion. And how to get there? We took the same sheath, the long one, and we are going from the right side to the left side, and we use the short sheath that we used at the beginning to tamponate the left common carotid artery puncture. So we did a crossover maneuver using the same Fortress 65 4 centimeter sheath. As you see, there is a combination of a 4 French Berenstein, 4 French Fortress sheath, and we can easily accommodate both sheaths in a relatively small, narrow common femoral artery. So I was able to navigate past the short sheath and engage the catheter and the guide wire into the left superficial artery. And you see, recanalization was pretty straightforward, pretty easy, just going through the soft lesion. And of course, we are starting with angioplasty, and unsurprisingly, there is a dissection, as you see in the middle image. And this time we use the new stent, new addition of Pulsar T3. As you see, there's different control mechanisms, the click wheel mechanism, like we see in most modern stents nowadays. The stent is being brought in. Our technician, I'm sorry, was not quick enough to record the deployment, so I can't show you the actual deployment, but it's much more controllable than the previous version. So this is the old one, trigger mechanism, and then the new one, when you just operate, you use the click wheel, and additionally, there's this triaxial mechanism adding for stability. So there is less jumping of the stent, especially at the beginning of the stent deployment. If If you look at the package, it's clearly marked. So you see the old version and the new version. It kept the same thin struts, adding to low chronic outward force and probably having, as a result, less in-stent stenosis. And otherwise, the stents are identical. So you see the situation post-stent being implanted, even without dilatation, the flow is already good. We still went in with a 5mm balloon, and this is the final result after post-implantation. So why bother? The company claims that we have many benefits when you use the 4 French platform instead of 6 French platform. This is just from the brochure from the company. Less bleeding. If you think about the sizes, it seems that going from 2 millimeters to 1.3 millimeters is not that much, but if you look at the cross-section, the puncture site area is almost 50% smaller, and you don't need a closure device. Is this the case? Let's check this out. We just decided to go for a simple compression, 10 minutes, not 3 minutes, not 5 minutes, not 8.5, just 10 minutes of compression. And we left this procedure, the patient like that. The patient was relatively thin, cooperative. We instructed him to stay in bed for a couple of hours. He was discharged the next day, but obviously you can see there's a potential for the same day discharge after a couple of hours. Of course, we didn't use any vascular closure devices, and no compression bandage was used in this case, as we would normally do if we didn't use a vascular closure device. So is a 4 French limitation? I think that means that you have simply more possibilities. It's very easy to upsize from 4 French to 6 French. It's never possible to downsize from 6 French to 4 French. And if you need to bring in a Viabahn, you still have to change the sheet for a 7 or 8 French. So why not start with 4 French at the beginning? Because 4 French allows you to do all the BTK work, all the SFA work. You have stent up to 2 millimeters, 200 millimeters in length. And if you want to stent iliac, the biggest self-expandable stent is 7 millimeters in diameter, which is suitable for most of our patients. Thank you very much.